we're ready to go?
Yes, that's fine.
All right, here we go. Good morning or afternoon, depending on where you are. I'm in New Hampshire in the United States, so it's a little bit early, but thank you for listening. So this talk is really mostly an introduction based on the thought leadership aspect of implementing technology into the evaluation of movement disorders. So especially for those who are involved in conservative physical medicine, a physiotherapist, chiropractor, kinesiologist, some folks like that. So we don't have a lot of time, so that's why we're not going to get in too deep, but this is basically bringing to light maybe an introduction to some opportunities that people didn't realize existed in today's conservative physical medicine, adding new technology and sort of bringing together what's been going around for a long time in some areas such as artificial intelligence to utilizing movement-based analysis and integrating those things to improve our ability to understand what's going on with the patients, as well as explain to the patients and improve compliance and adherence. So the two key points that I really want to make is utilizing locomotion assessment, which historically we often use what are referred to as surrogate measures. So individual things like range of motion, strength. Many of us have been using performance-based outcome measures as the performance aspect, but we also have an opportunity to use a performance-based measure to also obtain some of these more surrogate measures. Because of today's technology, we do have some overall health implications or considerations in streamlining the process that we can use to evaluate. And we'll look at something really, really simple in terms of what is consistent among a lot of our patients and using that as an evaluation procedure to help dictate and direct some of our care. So we'll basically just go through an introduction. The main topic that we'll be discussing in terms of movement therapy is actually going to be gait or locomotion, specifically walking. I do get into a little bit of running because this is a sports medicine conference as well. A basic discussion on a couple of pathologies, definition of artificial intelligence, and then we will get into a conclusion. I like to begin with the state of affairs, which basically means what's going on in our healthcare world today. Obviously, I'm from the United States, and so I used a lot of this particular data. But what we find is a lot of the patients that come to see physical medicine specialist, a conservative physical medicine specialist, meaning not a primary care, not a surgeon, but the physical therapist, the chiropractor, and those of that similar background, is we find that many of the patients actually have more than one problem. Oftentimes they come in and we're forced to diagnose a specific problem and treat their specific problem because of the way that a lot of healthcare systems work, or it's time. We only have so much time to actually work with the patients. In the United States, so if we look at the number of comorbidities or the number of problems that people have, more than 65% actually have more than one comorbidity as far as females, and it's even a little bit less with males, but it's a really, really high number, and it's something that we need to take into consideration and potentially do a better job at looking at the interplay between these comorbidities, such as obesity. So we find that we're close to 60% with being sedentary in the United States, and again, this is different among different global aspects or different target markets. We have a very, very high obesity rate and a pre-diabetes rate over 50%. So basically what that says is the majority of people that are actually going to come in and see us are going to have at least one or two or more of these particular things. When we look at osteoarthritis alone, $350 billion a year with direct healthcare costs associated with that and loss of productivity, meaning that people are out of work. So therefore they have to take a workers' compensation or other form of payment, and then the facility that they work for, the organization, also has to hire somebody else. So there's a great amount of associated costs that are both direct and indirect, and it tends to grow even more and more with a lot of conditions that otherwise many of us would consider basically conservative, and many of these things that could actually be preventative. So low back pain and neck pain is a global problem, and it tends to be somewhere in the top 10 within the global markets. In the United States, consuming approximately $135 billion per year. And then we can also look at diabetes being another one of those that is highly associated with inactivity, being sedentary, and so on. Other conditions that also are related to movement disorders, such as heart disease, dementia, hypertension, those are a lot of things that we may see that are going to come across and are implicated to part of the problems. So these are the top 10 diagnosis codes that we see here in the United States, and they're very similar between physical therapists and chiropractors. And as you can see here, they are all of a neuromusculoskeletal nature, including low back pain being that number one. So as an introduction to artificial intelligence, it's become very popular, especially due to ChatGPT, and we've seen it take the world by storm and even created a lot of new legislation around that. If you're not familiar with artificial intelligence or what it really is, it's a algorithm-based process that actually thinks very similar to the way that we do as clinicians. In other words, when a patient comes in to see us, we take a history, we may run certain lab tests, we may do certain neuromusculoskeletal tests, and we have to aggregate that information and come up with a diagnosis or at least a pathology or condition that we may want to investigate. So artificial intelligence works very, very similar to how a human thinks, but it aggregates that much more quickly. And it does that without the interpretation of emotion and other limitations that are associated with being human. So they're built on a lot of neural networks and mathematical models. And to give you a sort of an example that we may think about in terms of the physical medicine specialist is when, you know, we used to evaluate how we impacted a particular condition based on a single application, such as traction or shockwave or ultrasound. It wasn't until about 20 years ago that we actually had the mathematical statistical power to evaluate multiple or multimodal approaches the way that we actually did that within practice. But now we actually have tools that will actually aggregate all of that information even within the clinical practice. And those are referred to as these performance-based outcome measures. Historically, we looked at performance-based outcome measures as sort of the ultimate test of how someone is doing, especially in sports or athletics with regards to return to play. We may eventually have someone run some sprints or do an endurance test. So motion analysis actually allows us to integrate that based on today's technology, because we don't have to look at singular points of aspect with regards to the movement. And I'll talk about that here in just a moment. I often use a lot of automobile analogies, and here I have an example of looking at just how a tire wears. And so you could certainly fix that tire, but it's not really going to fix the problem if it is related to an alignment, something that's mechanical at fault within the automobile system. It could be over or under inflation of air. It could be something that's broken inside of that. So driving is actually this performance-based outcome measure. So in the clinic setting, because we have better technology to evaluate that, instead of just performing a range of motion test and a strength test, all of these individual aspects, we can actually combine these into a single aspect that many of us were actually taught within our academic preparation, which is known as gait. And from now on out, I'm going to refer to gait as walking, because gait has a certain connotation that we really perform that mostly in a laboratory setting that required a lot of very expensive equipment and a lot of very specific and detailed space. And many of us kind of moved away from that in terms of practice. Many of us might do it as an observational method, but we're not able to capture a lot of that information that we can see with the use of technology. So when we look at gait, it's a timed execution. And the reason that understanding this is really important is it brings together a lot of the biomechanical and neuromuscular aspects of how the body integrates and creates a very specific movement pattern. And so we break it down into both the stance and the swing phase. The stance phase accounts for 60%. And within that stance phase, we have a lot of other issues going on, including absorbing that ground reaction force, transitioning from a braking and using this pendular activity to providing a movement forward. And then we go into the swing phase, while the other foot is now in its contact phase. So there's a lot of neuromuscular components that are involved in this process. It's highly reflexive. There is also a voluntary component to it. And what's interesting is we create a lot of strategies associated based on the efficiencies or inefficiencies with regards to a lot of the conditions that we have. With today's technology, we're actually able to pick up on that. So when I say that we can't just look at this with the naked eye, something as simple as symmetry. So symmetry is looking at ground contact time. And what we see is variability once it starts to approach approximately 5% difference between the right and the left, it actually becomes indicative of a pathological condition, at least a limitation with regards to improvement in performance. And so we can use that as a very simple basic, but a 5% difference in contact time when we're talking about something that only takes a half of a second, 400 to 600 milliseconds, that's real difficult to be able to establish. The other one is going to be speed. So speed is something that actually provides us a whole lot of information with regards to the overall health of a person. As soon as a person starts to walk less than 2.4 miles per hour, that's actually indicative of a higher rate of morbidity and mortality. So in other words, people that walk less than 2.4 miles per hour actually may die 10 years earlier than someone who can actually maintain that speed. A cadence is going to be the combination between their step and stride length and their speed. And that should also be relative to how far and is indicative of something associated with balance. So movement analysis and using walking as a basic pattern to evaluate, we can actually use it to evaluate many, many conditions. In fact, we can use it to evaluate the majority of conditions that walk through our office as the conservative physical medicine specialist. From behavior and cognition, studies have actually shown that we can evaluate depression. We can dictate and diagnose depression based on just movement patterns. Neurodegenerative disorders such as traumatic brain injury to Parkinson's and Alzheimer's, we can actually evaluate and determine the progression of Parkinson's disease 4 years earlier than we could without the use of technology. And it allows us an opportunity to maybe intervene more rapidly. And studies have shown that when we can do that, it limits the progressive nature of many of these conditions and disorders, and maybe, just maybe, we might actually decrease the progression of something like osteoarthritis and minimize the number of joint replacements. Obesity, I think, is natural, as we can see that that's going to change the gait pattern. But the difference is that for all of these, what it provides us for is a lot of output that we use within the clinic. So there's no one tool that we use to give us all of the information and then actually show the patient, because compliance and adherence are a very, very important aspect. We find here in the United States that only 30% of outpatient physical therapy patients actually complete the course of care, which means that they're not actually going to get full recovery, and they're going to have a very high reoccurrence rate of that particular problem. It's going to cost more money, and eventually that may lead to surgery. So one of my examples here is looking at spinal pain or low back pain. It's actually my prediction that with the use of artificial intelligence and gait analysis, because there's several studies that have actually shown the fact that just improving a walking pattern reduces low back pain, non-specific chronic low back pain. So we're going to be able to actually dictate and see exactly what is causing what we now refer to as non-specific low back pain that you may not be able to detect simply by watching from an observational method. So we do see a decrease in walking velocity. Some of these things we can actually pick up, but if you've never seen these patients before, you won't actually know. Step and stride reduction, changes in frontal plane action, really of all the joints and including the coordination patterns. Studies have shown people with low back pain have an atrophy with regards to both the intrinsic and the extrinsic musculature. Latency with regards to the movement patterns, which are going to also influence the overall stabilization within the core, which is then also going to influence the lower extremities with regards to their performance in their walking pattern. So being able to detect this can be very, very challenging, but we can get to it sooner. And as we see this as one of the global issues within the world, and one of the reasons it's really difficult to detect earlier on with the naked eye is because we tend to wait until pain. And pain is a metric utilized a lot in the research as a performance outcome measure when in fact it's not. The absence of pain does not necessarily dictate an overall good performance enhancement. And in fact, we have a lot of strategies that the body will automatically conduct as a result of minimizing the effects due to pain and trying to maximize the overall benefit with regards to any type of performance. And here we're talking about walking because that's going to be one of the most specific ways that we can evaluate that. And it's one of the most basic movement patterns that every single one of our patients is going to be involved in. And again, several studies have shown that if we can improve the gait pattern of people with chronic low back pain, we can actually reduce their chronic low back pain. Balance, we look at, as a critical movement with regards to how someone creates their overall level of stability. So we could actually measure that individually, and many of us do that using various types of aspect, but you have to have a form of balance to be able to ambulate. So we're able to detect a lot of that while someone is actually walking. And that gives us a dynamic assessment because that's going to be very important at looking at the interplay and the interaction between things like rate of force development. So we find that in older adult patients, rate of force development is very important. And we're not saying that it's the same as necessarily someone who's going to be weightlifting, but rate of force development means their ability to generate force rapidly. And so every time that you take a step, again, if a contact time, the initial phase is only approximately 20 to 150 milliseconds, the time frame at which someone needs to respond or react to that is very, very quickly. Now, take that a step further, and if someone is involved in losing their balance, rate of force development or power production becomes even more important. So it's their ability to regain their balance after they potentially lost that balance. And that's actually one of the aspects when we look at gait mobility is we're constantly going through stages of balance and losing some of that balance. And so it's a natural process of that pendulum effect that we find with walking. So that loss of stability gives us that inability to recover. And especially in the older adults, we need to be able to assess that. So for example, here is an older adult who has a history of falls. This is an overground walking speed. So we see that she has a 9% asymmetry, which is indicative of not being able to coordinate between the right and the left sides. Her self-selected walking speed is way below what's considered to be normal, as well as her overall cadence. We see here that her overall stride length is very low between the two, and her stance and swing phase are also representative of her slow walking speed. So what's interesting is when I do this analysis, the artificial intelligence aspect of systems give us an opportunity. It tells me whether or not it's abnormal or normal, and it tells me whether or not it's going to be high or low, and it tells me whether or not it's the right or the left. The best part of this is it allows me to have that communication aspect with my patients so they can really resonate and they can actually see this. So we see that the stride duration on both sides is very long at just over 1500 milliseconds for each one of those. Very short stride length. We see a swing time, especially long in the right and basically normal, or especially long in the left, basically normal in the right. And we see that she has a very, very long stance phase. So like I said, she has a risk of falls, and therefore what we want to be able to do is predict and convince this patient that we need to actually do something about this. So when we further evaluate her walking pattern, we see that these are some of her strategies that shows me that she tends to walk more so on the inside of her foot. She has osteoarthritis on that right knee, so she tends to use the foot progression angle that's a little bit higher. She uses a very short angle when she comes into strike pattern of the ground. So here's something for the sports medicine folks that we do what's called stress loading. So I can actually evaluate, and as I increase the stress by simply having either someone run or walk at an incline or run or walk at a faster pace. So it starts to tease out and show me the degree of asymmetry, and also gives me some of the increases of changes in the patterns with regards to their strike forces and their strike patterns. We should, by just having approximately 8 to 9% difference in speed, we should see some obvious increases such as their cadence, But what we're starting to see here is there's an increase in the asymmetry, which results in being problematic. The other advantage that we get by doing something using technology is I see a widening of the variation. So we see that this is a normal pattern here on the right, but we see that the left is actually transitioning, and the person, and this is a ground contact phase, but we see that they have a very short heel strike pattern, and then they have a longer toe off. So this person actually has a cuboid syndrome, and we see that they have an inability to actually roll over to that side, which is indicative that they need a posting up on that particular area. So like I said, this was just a quick introduction, and now where do we go from here? We have opportunities to have low-cost devices that will provide us the opportunity to implement this within the clinical setting. We can do a much better job. We have moratoriums with regards to better return to play, better therapy, better compliance, and should reduce the overall healthcare costs. So thank you to Inovine and the Physiotherapy Congress meeting. Also, special thanks to my colleague, Dr. Rana, who is impeccable at organizing things, as well as the rest of the colleagues that I work with, just make amazing stuff, do amazing work.
Yes, thank you so much, sir, for joining this event.